Okay, well, in the interest of time, I'm going to go ahead. Welcome to the Transosseous update for the modern-based era in 2020. We've got a great faculty here tonight, ranging from thought leaders and scientists and academic guys to private practice surgeons, and they all have their own unique perspective, and we hope to have a good discussion. Thank you for the attendees for your time joining us tonight. In your busy life. I know it's hard, but hopefully we'll keep it dense information that's practical and good. Make sure that you're using the chat function if you want to ask questions. We'll try to get to them. And the purpose of this meeting is to educate about new developments in this technique, which has come back around. I believe this is one of the first open discussions and really in North America since sort of the early 2000s when the technique started. Hopefully we'll dispel some myths and do some education, maybe talk about some future directions. And there's a bunch of ways we can go with this in the future. So, so with that, I'll bring up my intro, which is there. And share screen. Okay, so Brett Sanders, I'm in a private practice group in Chattanooga, Tennessee, and I do have a relevant disclosure. I'm the founder and inventor of a transosseous repair device, and we're sponsoring this. This journey for me started with the problem of value, which we saw coming in fellowship. This concept was brought about by Michael Porter at the Harvard Business School. It's defined as outcome over cost per episode. There's been a lot of theoretical discussion about this, but it's had some trouble kind of getting into practice. In the States, this manifests as bundled payments. Bundled joints have been around for a long time. Our international colleagues will know that there's single payer systems, so there's value propositions there. Simultaneously, we've had technological convergence and commoditization of anchors. So basically, an anchor is an anchor, and there's at this phase, and there's really not much difference in them functionally. So this is an opportunity. And at the beginning of this, I really felt that we had at least non-inferior outcome, if not superior. And definitely we had cost effectiveness with these techniques. E.A. Codman, was the first transosseous cuff repair, first cuff repair 100 years ago, the father of value-based medicine and evidence-based medicine. And he was measuring value with cuffs. And that didn't go so well for him in his time, but now his principles have come back. So I'd like to introduce this concept of the rotator cuff repair cycle, which I believe is Castagna's concept. And there's basically a logical cycle back to transosseous techniques as they evolve. So, we started with this transosseous repair, and this transosseous cerclage effect is extremely powerful at reproducing the footprint. And this is kind of what we're chasing, basically. And then we went to transosseous mini open with or without augmentation. So you can do that with buttons, tapes, screws, plates, anchors. There's a bunch of ways to skin that cat. We can talk about that. But we came to anchors, mini open with anchors, and the transosseous equivalent. And then when we came into arthroscopic technique with single anchor repair, this is where we got stuck here. The failure rates, clearly went up with Yamaguchi and Bishop's study, 90 and 80% failure rates at that time. And given these were double loaded anchors, and maybe triple would be better. We didn't really know about the crimson duvet at that phase, but it clearly worsened outcomes here. And so we kept working, and the industry kept chasing this transosseous cerclage effect. How can you do the same thing transosseously with anchors? So we added a couple thousand more dollars of anchors and bone voids and inert material in the healing zone and overly stiff compression, decreasing vascularity, causing an induced failure mode, bringing up a new failure mode, the type 2 failure. And that's kind of where we are now. And this is driven more by biomechanics and technology and chasing the transosseous cerclage effect than it is by biologics or outcome. And So this is where I spent a lot of my original work on these hybrid techniques, trying to step surgeons into full arthroscopic techniques. So this allays a lot of their concerns and stepping into that sort of like mini open to arthroscopic until we can get people comfortable with arthroscopic transosseous techniques and then getting back to doing the whole thing without anchors. It's my position and belief now that, you know, transosseous cuff repair is the gold standard. It is and was the gold standard. And we know that all the giants of shoulder surgery have used this technique for years. We definitely have a lot to talk about in terms of cost and value. The biology of the healing side is exceptional, and we've got access to stem cells. The biomechanics is basically the same or superior depending on what you read and who you talk to. And the pain is reduced, level 1 evidence on that we can talk about. And if you talk about biology and pain, just if you look at these, look at the tendons on MRI, you get this excellent healing response without the Sugaya 3 failures at the articular margin, and it's really a biologic repair. Revision considerations are excellent. You don't have any anchor voids or hardware to miss, and you can do any technique you want. Outcomes have been excellent. There's not a whole lot of studies, but there are long-term studies now, and it has synergy with all kinds of other technologies. So there's a lot of ways to go with this. Historically, there's been a lot of people that have made a run at this, and I think that lends to its credence. I will call to your attention, if you haven't read Kuroda in Japan, you know, he's got a great 380 people, I believe, series with 94% healing rates, and an interesting technique, but a great clinical series as well. This is just a slide to show, this is from JBJS, Dirk Stingel, pointing out that most technologies that we introduce don't have much difference. And the things that we think are game changers are really not, when you look at them objectively, they're really, because of sealing effects, it's very, very difficult to show, you know, a true difference. So I think this is kind of where anchors and tunnels are. It's kind of like down at the bottom right, locking and non-locking bolts in trauma. It's going to be very hard to show a difference there, except on cost. So what is the ideal repair? This is just principle-based thinking, mostly from Gerber. You want high initial fixation strength to resist ultimate and cyclic failure. I think you can see those repairs have a capability of achieving that. We want to prevent gap formation and reduce shear forces. As you can see, the contour of the greater tuberosity there with these tapes in this massive 3-tunnel tear here, we're reducing the shear force. But we also want to go a step further. We want to reproduce the anatomy, and this South Korean paper shows how when you get bird beaks and dog ears in your repairs, it's really because you're trying to repair you don't have enough fixation points. You're trying to repair a cuff that needs 6 anchors with 4 anchors, and that's why you get deformities. We want to avoid these bone voids through vision considerations. We want to be mindful of this medial stress riser, which is creating type 2 failures and causing tendon transection, which is a catastrophic failure mode. Of course, we want good outcomes, and we've got one of the experts here with 2-year ultrasound follow-up he'll talk about. But I'd like to suggest some new ideals as well. So I'd like to suggest that we should be paying attention to improved biological healing assessment on MRIs and perhaps ultrasound with Dr. Cruz here. We want to be mindful of bringing in biology, and here's an SCR that we did. We want to use our patches and augments and biologics and reduce the cost ceiling for those. We want to improve the vascularity, and there's clearer evidence on that with transosseous techniques by ultrasound. Of course, we want to recapitulate the anatomy as we can easily, but we want to avoid these pressure spikes, and we want to increase our fixation point density. So with that said, I'll say after 8 years of going deep on these concepts, there's a couple of things I've learned about adoption. The things in red: safety, efficacy, theoretical concerns, biomechanics. This is what we talk about, and they're important, but that's not typically what moves the needle on adoption. It's mostly, you know, I've found ease of use, familiarity, incentive, payer mix, health system, but a lot of psychological factors as well: risk tolerance, dogma, and a lot of social aspects. So I'd like to give a shout out to our Italian colleagues, Dr. Castagna, and they're doing a lot of basic science for transosseous techniques out of Italy. They've been very open-minded on the science behind this and driving this as a worldwide grassroots phenomenon. So with that, I'll hand it over to our next speaker, Dr. Srikumaran, who is an academic shoulder surgeon at Johns Hopkins, and he's done a lot of basic science and clinical research on transosseous techniques. So, Uma, if you want to take it. Make sure you're unmuted, Uma.
There we go. Sorry about that.
There you go.
You got the screen okay? You guys can hear me?
Yep.
All right, perfect. Thanks, Brett, and thanks for organizing this and inviting me to share our experience with this. It's a great opportunity to learn from others who have taken on this approach, and appreciate your efforts in this area. So I'm going to talk about this, as Brett mentioned, from a green perspective and what that means for all of us. So I don't have any disclosures related to transosseous technology. In fact, some of my disclosures are actually with anchor companies. So just take that as you listen to this talk. Our objectives, as Brett's already outlined, the evolution of rotator cuff repair. So we specifically look at this according to transosseous technology and comparing it to what's considered to be the gold standard in anchored approaches, which is that transosseous equivalent. And then spend a little bit of time on the biomechanical concepts, and I'll review our latest clinical outcomes and I'll try to show it to you from a green perspective. So why should you care about this green approach? You know, maybe it's just that, you know, you hug trees. It's okay to be an environmentalist. That's great. It's a way to reduce recycle or reuse things, and maybe you just don't like to waste, and that's always a nice approach. Or maybe you just hug money. Maybe the green is about the money that Brett's referencing to. But really, I think green is about value, and Dr. Matson speaks about this really well in regards to all kinds of different technologies in orthopedics, and I think transosseous fits the bill perfectly. As Brett mentioned, the evolution from both our approach perspective as well as the constructs that we use. Anchors were great to get us to a fully arthroscopic approach, and as that's evolved, the question really becomes, can we get back to an transosseous approach done fully arthroscopically? I mean, there haven't been any studies that have demonstrated that an arthroscopic technique is better than an open technique. So it's just really a patient-driven thing that they want the surgery performed arthroscopically. So can we do it in a fully transosseous manner, and how do we get there? So this is my preferred approach or technique. It's very similar to doing these rotator cuff repairs with anchors. You place a pilot hole in the same fashion, and then you can use an instrument. Instead of inserting the anchor, you can insert this hook device and connect it to a lateral tunnel, and you have a passing suture which you can then apply any number of sutures to, or different types of sutures, tapes for example. You complete your construct in a very similar fashion. So if taught this way, I think it is accessible to residents and fellows without a problem. And then, as Brett also referenced, this cerclage sort of compression of the rotator cuff is ideal in many ways. So let's review that from a biomechanical perspective. So some of the literature would suggest that a transosseous equivalent with the anchors, as you can see on the left, has extremely high failure loads, and which is why it's so popular. But even transosseous technologies can have extremely high failure loads, as well as low gap formation, and achieve larger footprints than we can expect from anchored points. As Brett was also mentioning, single anchor brings you down to one area. How can you spread that out? So a lot of the studies will suggest the transosseous equivalent has high type 2 failure rates, or muscle tendon junction failures, compared to transosseous approaches that have a much lower rate of muscle tendon junction failures. And if they do fail, they're going to be tendon from bone again, which is much easier to revise. So in this study that we performed with matched pairs, you can see the highest percentage of type 2 failures were in the transosseous equivalent or anchored approach compared to the tunnels. And that's exists with other literature as well. Kim et al. In 2016, again, finding type 1 failures. But what about, type 2 failures mostly in the transosseous equivalent group. But what about tissue perfusion, the other side of this, that what you get with excessive compression may be sacrificing the perfusion of the tissue. And this was demonstrated in a rabbit study by Kim in 2017. So the initial conclusions from some of this biomechanics work would suggest that anchored TOE constructs do demonstrate higher failure loads than TO, but the transosseous constructs are quite high themselves, maybe not in absolute terms, but we're going to show you why this may not be correct. And then the failure mechanism is pretty well established, individual studies as well as large reviews. So how can we assess some of this work, and what other factors are associated with construct strength? So when we did a systematic review and a meta-regression of over 40 separate papers about the biomechanics, specifically rotator cuff repair constructs, we identified some independent covariates. So suture type, number of sutures, number of suture limbs, the number of mattress stitches, and the number of anchors, and finally construct type. So is it a double row transosseous equivalent, a single row, or standard double row constructs? And then we looked at failure load and failure mode. And really what we find, it's really all about the suture. So the strongest predictors of repair strength relate to, one, the number of suture that are used, and actually the number of suture limbs that are passed through the actual tendon, as well as the type of suture. So dimensions of the suture, whether it's a wide bore or like a tape versus a cord type suture. So when you control for these factors for suture material, there's no difference in rotator cuff strength between any of the construct types. So single row, double row, TOE, or transosseous technique. So you can achieve any strength you want in terms of load failure based on your use of sutures and the fixation points that Brett mentioned. So the other findings again confirm that TOE repairs are associated with high type 2 failures, as referenced to either concentration of force along the medial row that might be too high. So when we consider this contact area and compression, which we're trying to achieve with any technique, the TOEs have shown favorable compression areas compared to other anchored approaches, but not compared to a transosseous approach. It does have the best contact area when you do a fully transosseous technique where all the pressure is down evenly across the cuff tendon into the tuberosity. But with compressive ability, that goes hand in hand with tying the medial row for anchors, and that leads to the type 2 failures that we're talking about. So the best balance really comes with respect to contact area and compression is with the transosseous repair. You can achieve this large contact area, a favorable compression pattern with high contact pressure, all things you need for high healing rates. So this you can get this compressive pattern without using that medial row compression and getting that stress riser, and therefore avoid that type 2 muscle tendon junction failure. So moving on to our clinical experience, this was recently published, our matched cohort of rotator cuff repairs in core. We basically looked at the gold standard in an anchored approach, which is the TOE, versus a fully anchorless transosseous technique, and compared both clinical as well as patient-reported outcomes with ultrasound follow-up. And we had a minimum 2 years of follow-up. So this was retrospective, but matched for sex, age, tear size, smoking status, all the important confounders for rotator cuff healing. And our primary outcome was the ASES score, and we powered it to detect the minimal clinical important difference of 12 points. And then the ultrasound was performed at 1 year separately by a blinded, the interpretations by a blinded radiologist as to the surgical technique. So as you'd expect, the results are equivalent, regardless of 1 year or 2 year follow-up. ASES score, the subjective shoulder value, were similar across groups, and pain scores also at 1 and 2 years were equivalent. The range of motion and functional outcomes were also similar, and the ultrasound evaluation was equivalent. When we broke it down by size, of course, that's the biggest predictor of your healing rates. This was equivalent across transosseous as well as transosseous equivalent approaches. So conclusions here are that both groups can achieve clinically meaningful outcomes. As Brett also mentioned, this is a bit of a surgical sealing and rotator cuff repair. We have a lot of good techniques to get healing to happen and clinical outcomes to improve with respect to our PROs. There's no significant difference in procedure duration or re-tear rates and any clinical outcomes. Of course, this is still a retrospective review and a single institutional experience in terms of our limitations. But this was our first adequately powered study to detect the MCID for the ASCS score with clinical outcomes beyond 2 years, which were equivalent re-tear rates, again, equivalent with equivalent resources in terms of operating room resources, but significant cost savings if you look at the implants themselves. So takeaway points are that the biomechanics can achieve similar strength, and it's really about the number of sutures and how you place them and the suture type as well. Clinically speaking, we can achieve equivalent outcomes. So if your costs are similar, this is a very simple cost minimization analysis. So your value is going to be much higher should your costs be lower and your outcomes are equivalent. So this represents much greater value. So can we go green? So speaking to the point of adoption, it's an additional tool, and it helps if you can teach it in a way that's very similar to anchors because they dominate the market. But it is also an opportunity to disrupt this market and really drive the cost of anchors down, and also further innovate in the transosseous space and make it easier and simpler for everyone to achieve these types of outcomes. We've talked about this surgical sealing and finding the most affordable way to allow us to shift more to the biologics, which are going to be expensive, especially initially. So this opens up that opportunity for even cost restrained or bundled environments to start looking at those things. So really being green is about less waste, especially plastic, all these disposable anchors, and each handle is thrown away, being less expensive in general, having a higher margin if you own your ASC or have any involvement with that, it's important. And finally, most importantly, you're achieving an equal or improved patient benefit. Thank you. Let me stop sharing here.
Okay. Do we have a question?
From Stefan Snyder.
Uma, did you, I may have missed it, did you show any difference in the ASCS scores of the anchor versus transosseous? It seems like the transosseous have very high ASCS scores because of the pain, slightly higher it seems than anchors. I don't know if you've noticed that or not.
So we only, not in this study, because we're looking at it at 1 year and 2 years. So by then everything kind of washes out. Everyone's going to be the same. I think if you measure it at 6 weeks and 3 months, in that time frame, you'll detect that pain benefit that a lot of folks have demonstrated or know anecdotally from their own experience, that the transosseous technology seems to have less pain. So that gets reflected in an ASCS score early. But at the end of the day, by a year, they're all the same.
Right. Okay, great. With that, let's move along to Dr. Lazarus, who has a very long-term experience with transosseous and has done a lot of studies clinically on transosseous techniques and can teach us all a lot about how this works in a resident teaching situation and with complex techniques. So go ahead and take it away there, Dr. Lazarus.
Great. Can you hear and see me?
Yeah, looks good.
Wonderful. Well, first of all, Brett, thanks for inviting me for this webinar. This is really great. You asked me to talk about my experience at a large academic institution, which I am at, but you also asked me to talk about the economics of this type of procedure. And I'm also a shareholder in a large private group. So the economics of this are not just academic for me. And so when I talk about that, it's not just an academic area of interest. I have no disclosures relative to this device. I just like using it. So the 4 things that Bray asked me to talk about is just a little bit of my experience, some technical pearls. Again, talk about the economics of transosseous, and I call anchorless rotator cuff repair. A word on the use of grafts and biologics, and finally cortical augments. So when people talk about reasons to not tunnel, the big thing that comes up is suture management, and the suture management it's too painful to do. I've got a partner who always uses the F word before he mentions tunneling. And actually, the suture management is the advantage of tunneling because it's in our control, and so we're not limited by anchor configuration. What I mean by that is you have more ability to add points of fixation for the same amount of exposed tuberosity. We're not limited by having a 1 centimeter bridge between anchors or the number of sutures within an anchor. You can come up with any configuration you want. That being said, you really need to have a plan in terms of suture sequencing, in terms of management. I make use of colored hemostats, and as I'll show you, varying different colors and types of sutures just to keep track of things. So Gary Updegrove, who's one of our former fellows, put this together. It seems really complex, but in fact, this is just a PowerPoint. He did it for himself, but he now shares it with all the fellows. So this is a 3-tunnel repair, and these are the 10 steps that you take by passing these sutures in this configuration. 10 steps later, you have a transosseous double row repair with multiple points of fixation. And again, it seems complex, but once you think of it in sequencing in those terms, it becomes very, very easy. And so hopefully, so I boiled this down to a 1-minute video. So this is a tear that ended up being 4 tunnels. And so then this will be a double row repair. We could talk about, if you want, whether or not you need a double row repair for this transosseous technique. But this is the Tensor tunneler. I'll put a passing suture through, and then you can pull anything you want through. And so I use tapes, and I use suture for the medial row. And so again, you can see the 4 tunnels with different tapes, different sutures, and then it simply becomes a rotator cuff repair. And so you pass sutures. This is how I tie the horizontal mattresses, just bringing one limb from 2 consecutive tunnels out and tying them together with a non-sliding knot. You create a medial row and also a rip stitch for the lateral row sutures to bridge across, as I'm showing you here, without having that single point of fixation down to a single anchor. So this is what I just did 2 weeks ago with my PA. And this is 4 tunnels. Again, you get that spread of suture that Brett talked about earlier, so you don't dog ear as much. You get the ripping effect of the tapes going over the horizontal mattress suture, and you get the footprint compression effect of a double row repair. So all the things we really want to do with cuff repair. So several years ago, Eric Black, one of our fellows, did a retrospective study looking at my patients and cost double row anchor versus transosseous. And what you can see here is, as you would expect, I don't know if you can see my cursor, but for the transosseous technique, the cost is the same. The cost remains stable regardless of the size of the tear. But obviously, the larger the tear, the more anchors you use, the cost of the anchors goes up. And so for the large and massive tears, the cost difference becomes substantial. These were my first tunnels relative to already being very experienced with anchors, yet the surgical time was the same. So it is not a procedure that takes longer. Adam Seidel's now at University of Colorado, then did a prospective study with us when he was one of our fellows. And again, the cost differences in this study was even greater. And so for large and massive tears, the cost difference was over $1,000 per case. And that adds up. And based upon simple shoulder tests, the results were the same at 3 months, 6 months, and over a year. So outcomes were the same, cost dramatically less. I don't know if anyone has experience with constructing a bundled payment model, but we have done this. And so we have constructed a bundled payment model for rotator cuff repair. And this is the first step. The first step is looking at cost data per surgeon. And the reason it's this important is, number one, insurance carriers are most interested in bundled payments when there's a large variation between cost per surgeon, because they would rather we take the risk than they take the risk when there's that much variability. And number two is, obviously, the more outlier surgeons you have, the more likely you are to break your bundle and lose money on the bundled payment. And so I can't show you the absolute numbers, otherwise my CEO will kill me. But this is me as baseline. This is our hospital. This is, by the way, up till last month. So this is our hospital, our surgical specialty hospital, and these are the 4 busiest cuff surgeons. And what you find, so I'm 0 because I'm the lowest, and then these are the differences above me. And so what's really interesting is me and surgeon B do all the massive tears, do all the grafts, do all the revisions. The insurance carrier could care less, and our hospital administrator and our CEO could care less because it's all one bundle. And so the surgeon B happens to be a very good surgeon who's very cost effective. He's doing all these graft revisions and he's just $700 above me. It doesn't matter. They hate him. Surgeon C does only the smallest tears. He only does single anchor tears. They love him. And then surgeon A is not going to be doing rotator cuff repair very long at our hospital if he keeps doing this, because he does not do all the revisions and he is $1,400 on average above me per case, despite the fact that I'm doing the more difficult ones. So if as we do more revisions, as we do more SCRs, things like that, all these things are included in the bundle. And so you have to try and trim your costs somewhere. And Bob Tadgen years ago published a paper looking at the single best way that you can trim your cost of cuff repair is by lowering the cost of anchors or just not using them. So a word about graft augmentation. I showed this video before, but the reason I like tunneling for graft augmentation is the procedure is no different. The steps are almost identical. Instead of tying the horizontal mattress like that, I actually pass it through the graft and then tie it. And so once you do that, you essentially have the medial side of the graft fixed down with the medial row of your rotator cuff, and then you're just tying the tapes over the top. So it really doesn't add any significant number of steps to what you're already doing, as opposed to when I did these with anchors, it seemed like it was just a completely different procedure than rotator cuff repair. This seems to be the same thing, just adding a graft for reinforcement, for me, primarily for revisions. And then Brett mentioned SCR. SCR is limited by cost. It's an extremely costly procedure. And so if you eliminate your lateral sided anchors, you can really, if we show some effectiveness of this down the line, make it a cost-effective procedure. And so, yes, I use tunnels on the lateral side for all my SCRs as well. So, we hear a lot about the future biologics, biologically active suture. You hear about this all the time. And I always say to myself, well, does it really matter if the suture is attached to an anchor, because the suture is not really exposed to the marrow. We hear about marrow stimulation, either locally or systemically, medically. And again, I always say, well, does it really matter if the marrow access to the undersurface of the rotator cuff is being obstructed by numerous anchors? And so I think that tunneling really lends itself to these future biologic techniques. Grant asked me to mention cortical augments, probably because Grant Garrigues, one of my former fellows, insisted on writing this technique paper years ago. And so this was a device meant for open surgery, which we used for arthroscopic surgery for tunneling. As Brett mentioned these, I've used generic augments, I've used specifically designed augments, polyethylene patches, 2.4 millimeter plates. But once I switched to tapes, cortical augmentation for me is a once every other year phenomenon. These tapes just tend to not cut through bone. And if you really focus on making the lateral aspect of your tunnel as far distal as possible by abducting the arm before you seat the tunneler, cortical cut through a rare occurrence at this point. Okay. All this great science. Best reasons to tunnel, and that's how I'm going to end my talk. So best reason number one, we've all had these patients who want their rotator cuff repair to be the hardest one you've ever done. And so they say, Doc, how many anchors? You say, none. Reason number two, for the patient, we've all had these patients, right? That they're 6 months out from surgery. The repair is good, but they're still having pain. You send them for the MRI scan. And because you didn't use anchors, there's so little artifact in the greater tuberosity. The official radiology reading is normal shoulder, right? There's the tunnel. They don't even recognize that this patient's had cuff repair. And then the most important reason is when you have that annoying partner who wants to impress you with their 8-anchor rotator cuff repair and can't stop talking about it, you can say to them, anchors are so 2010. Thank you.
Great talk, Dr. Lazarus. Really hit on a lot of important topics. I wasn't aware that you guys had done provider-initiated bundling, but that's what I'm trying to tell people is that if you have that bundle, you can bundle in the cost of the anchors for a higher margin, and the surgeon's discretion to not use them, and then that's margin that you can maintain that delta. Correct?
Except that the insurance carrier is not going to go for that. You know, the
Yeah.
insurance,
So they'll just look at the data and do what they do.
Bundle. I mean, you know, the experience with the joints is that, you know, the bundle payment plans have been a race to the bottom. And so I think that the carriers are smarter now because they realize nobody's signing on for these bundles the way it was. And we're smarter now. We've used our experience with the joint surgeon, with our hip and knee surgery bundles and our shoulder bundles to recognize how to construct the bundle. And so we're not going to construct the bundle that has the payment including 8 anchors per case, because there's no carrier that's going to sign on for that. But that being said, the tunnelers are driving down the cost of the care, and so our administrators want everyone else in our practice to do cuff repair for the cost that I'm doing it for.
Yeah, that plays into, we had a question from Dr. Schneider. Hey, Dr. Schneider, he's kind enough to join us and ask some questions. He was asking about the cost of transosseous versus single anchor versus double row. And I think your study would show that it just goes up, per anchor, right? I mean, because we're a fixed cost with tunneling.
Yeah, at our institution, the break even point is somewhere around 1 3/4 anchors. So once you use a second anchor, the tunneler becomes more cost effective at our institution.
Right. So in the optimization equation of surgery that the bundle forces on you, or that increasingly just every surgery is an optimization problem of time, money, outcomes, technology, et cetera. It's making us look at these things. Can you repair a cuff adequately with 1 3/4 anchors, or would you rather have multiple unlimited fixation points? Time, you mentioned you make up some steps with your patches because 1 tunnel is the equivalent of 2 anchors. And I believe, didn't your study show time equivalence?
Time is equivalent for everything except small tears. Small tears, the anchor won out. Other than that, for moderate, large, and massive tears, the time was equivalent.
Okay, great. Very good. And I think we had another question from Dr. Schneider about, do the panelists believe that the cuff will regenerate with the crimson duvet, or are we trying to make the double row footprint? I would say I believe that it will reconstitute some fibrous material that will look similar to tendon, but probably won't be a collagenous fibril attached to the muscle architecture, like the original tendon was. So I tend to be a double row guy, which has been, a full foot, if assuming the tension's okay, reconstitute the entire footprint. The surface area of the double row, reconstruction has been linked with less re-tears. That would be my answer.
Yeah, I would agree with that. But when I teach the residents and fellows, I always say cuff repair is a battle of tension versus coverage. And so if you can gain coverage without excessive tension, I think the literature would suggest, at least for large and massive tears, integrity should be improved down the line. If you can't, then I think a single row, more medialized repair is warranted.
And do you guys ever, you can do a transosseous technique and just not go as deep, right? Like, to me, you're doing the same thing as you're doing a medial row. Like, you're just not taking as much tendon laterally, right? It's achieving the same thing, but you're still laying the tendon down. And I agree with you. It's just a matter of tension. And I understand the idea of a single row, but.
Yeah, when the tension's high, one of the things I do is, like, often you'll have a chronic supra and acute infra. So infra double row, the chronic supra that's under a lot of tension, do a tunnel, and then use arthroscopic Mason Allen sutures like Lafosse locking loops to essentially do a single row, and then you just tie the knot low and lateral. So it's a single row repair just without an anchor. Awesome. And I see we're getting some chatting here, so that's good. Why don't we move next to Dr. Brodigan? And Dr. Brodigan is in private practice in Ohio, and he's been a longtime tunneling expert and has taught many people how to utilize transosseous tunneling. So we can benefit from his input here. Take it away, Brad.
Thanks, Brett. I'm trying to get to the play button. There we go. So, Mark, that was great talk. Uma's talk was very good as well, and Brett, your intro was fantastic. So there's not a whole lot of room here, but I come at this from a private practice perspective. I have ownership in a surgery center, and I'm definitely involved in cost containment and trying to reduce the amount of spend that we have per case because it affects our bottom line. That definitely makes us a little bit more intimately involved in the cost per case. So I'll come at it more from the private practice perspective, and also I have been doing this for a while. My history with transosseous repair, starts with, just learning rotator cuff repair as a resident at Akron City Hospital. I worked with Rob Bell, who was just starting to transition to arthroscopic rotator cuff repair with anchors. I did a sports medicine fellowship at the University of Kentucky, and we did 99% knees. And so there wasn't much going on for that year with regard to the shoulder. But in practice, I went and visited Garrigues. He had like a weekend fellowship type of offering, and in a 2-day clinic that was very well organized. He taught me how to do arthroscopic rotator cuff repair. It was really, really exceptionally well done, and it makes me feel optimistic that anyone who would want to learn how to do this technique. Now, Gary taught me how to do it with anchors, but I feel the same methodology that Gary used to teach those of us who wanted to transition to arthroscopic rotator cuff. Those same steps and techniques of teaching, I think, are applicable to this methodology. And it can be that quick. I came back from a 2-day clinic with Gary and just got right into it, and I haven't looked back. From there, I was a arthro-tunneler test site surgeon, and we started off with a device that looked much like the Tensor device, in that it was a reusable device. It was heavy, it was sturdy, it felt great in your hands. And then after the testing was over, they went to the disposable. And I've been an arthro-tunneler user since the beginning. And according to Tournier, I was using the tunneler. I was second place only to Butch Christian as far as use of the device. So I've been doing this for a while, using this type of technique. I started to use the Tensor device, and there are some differences between the Tensor device and the Arthro tunneler. The Tensor device is far more sturdy in your hands. It's far more predictable with regard to the initial pass of the suture through the device to the eyelet. So it is more efficient in my operating room compared to the Arthro tunneler. Both get the job done, but the Tensor device does have some advantages. My experience from the other side is that I had a rotator cuff repair and a biceps tenodesis. It was done by Butch. I had it about 1.5 years ago. So that meant I had to fly to Texas to have my rotator cuff done from Ohio, and it was well worth the trip, I can tell you. I've had a fantastic outcome, and I'm a believer. So why would we use this technique? I think everyone has touched on this. The transosseous technique is the gold standard. You can use it open or arthroscopic. For those of you who are still doing open cases, there's no shame in that, but this technique is still applicable to that. The reduction in cost is dramatic. And, I'm intimately involved with looking at these numbers, and A break-even point traditionally has always been discussed at like 1.5 anchors is the equivalent of using an arthrotunneler for many years. And I've looked at it with the Tensor device, and it's between 1.5 and 2 anchors. So anytime you're, and that's average anchor price. So if you're looking at an average anchor price of, anywhere from $250 to $325, once you get beyond 1.5 to 2 anchors, you're spending more than you would if you were using the Tensor methodology. The biologic advantages, I think, are undersold, really. I think venting the greater tuberosity and having access to the bone marrow is a tremendous benefit with this technique. I don't think we talk about it enough, quite frankly. It reduces the pressure head within the humeral head, and my patients have far less pain postoperatively than my partners who use anchors. I think the reduction in pain is from the venting and from the reduction of the pressure head. The marrow venting right into the site where you need the bone marrow is just a tremendous advantage. And I've had, actually, I haven't looked at the numbers, but I am not afraid of repairing a smoker because of this technique. I don't have large failures at all, really, but I don't have large failures specifically with smokers. I try to get them to quit, but because of the biologic advantages, I think it actually overcomes some of the disadvantages of working on a smoker. The other thing that, as far as cost containment, if you're doing a biceps tenodesis in the same case, you don't need a separate anchor or fixation device. You can use the transosseous technique. The Tensor device and versus the arthrotunneler, again, I think it's a little bit more sturdy in your hands and much more predictable in that passage of the suture through the device. Once you pass it into place, I haven't missed yet. The suture might drop once in a while, but I haven't missed actually getting the pin to go right into the eyelet on every pass. So that's helpful because we don't want to pass through the greater tuberosity any more than we have to. I like simple sutures. I don't like complex constructs or ripstop sutures. Gary impressed upon me the fact that we want physiologic tension. He impressed upon me that we're soft tissue surgeons. There has to be some touch, some feel. Simple sutures with knot tying is all that's really required. If you need additional fixation, you use an additional suture. I don't think we need terribly complex patterns to get a good result. I think if you use simple sutures, you leave the cuff in a position where it can find its home. So if it is a little bit overtensioned, it can pull back just a little bit and find the appropriate tension for healing. If you use ripstops and if you try to lock that thing down at time 0 with maximum tension, you're a setup for failure that way. Gary he actually liked Ethibond for rotator cuff repairs. And I asked him why, because we had better sutures at the time. And he said he liked the fact that if he was tying the knot too tight, it would break. So he never over-tensioned a rotator cuff. So with some of the stiffer sutures that we use, I think we have to be really careful about how much tension we're using when we tie them down. I thought that stuck with me for a long time. And this picture of the Lilliputians holding down the giant with just simple ropes and ties, all they had to do was add suture. So we've seen this slide before. This is one of Mark's slides, and my repairs look very similar to the repair that you see on the left. I have used augments like Mark does, and the grommets that you see there on the lateral side of the repair. I've used that. Tournier came out with a grommet technique, and there was a question already in the chat room about what do you do with bad bone. So what do I do with bad bone? I don't use grommets. I really don't. I use maybe a few more sutures, and what I do is I make sure that I balance out the tension with each of those sutures as I'm tying so that I'm not overloading any individual suture. I use a physiologic tension with each suture. And if I use multiple sutures with low tension or physiologic tension, if you know, is probably a better term, but lower tension for bad bone, then you're not going to have a bony failure or a cutout. I've been doing this for a while. I have not seen that problem in my patients. And I always check my lateral tunnel to make sure that I don't have cutout. That's a checkpoint for me. After I finish the fixation, I'll look at the cuff and then I'll put the scope in from the lateral side and I'll look directly into those passage points to make sure that I don't have cutout. So I thought I'd show you guys a case that I did yesterday. I took lots of pictures. So this is going to be a rotator cuff repair and a biceps tenodesis. And this is one method by which I do the tenodesis. There are a couple of methods. Brett has some really brilliant videos of his method using fixation that he does in the groove. I actually am going to fix this biceps to the tuberosity. So this is what I saw yesterday. I think all of us see this quite a bit. One of the reasons I don't like screw fixation for a biceps like this is that with the biceps being a little beat up and frayed, sometimes during the passage of a screw, you traumatically transect through the biceps. So I'd much prefer to have suture fixation here. So I'm just going to debride the biceps a bit, debride the rotator cuff. I'm looking at the footprint that I want to bring the cuff back to very directly here. So I'm going to take advantage of that. I'm going to create a little bit of exposed bone for my biceps to come back to and the cuff. And then I'm going to create my transosseous tunnel while looking from the articular side of the tear. And I've punched through the greater tuberosity to initiate my transosseous tunnel. And you can see my transosseous tunnel. There's a little bubble. There's a little fat coming up from the marrow, and the tunnel's ideally positioned. Now I'm going to suture my biceps tendon. And I want to have a good suture through the biceps tendon with a locking technique. And so after I pass it with my nitinol needle passer, I'm going to make some passes around the biceps and create a locking stitch. Then when I pull the biceps tendon back through the rotator cuff tear, I'm going to see where that biceps tendon is going to end up once I pass that suture through the transosseous tunnel. It's going to get tucked in right there, and my cuff repair is going to come down around that. From here, I'm going to go to the subacromial space. I've done my decompression of my distal clavicle excision, and now I'm passing my suture with a Tensor device. Now I'm passing my suture through the cuff. I've got 3 sutures for my cuff repair. And the knot that you see there is tied down on the lateral side. That was my biceps suture that I passed transosseously. I pull the biceps into the repair site and tie it down with the lateral knot. It was a small tear. I tried to peek in through the rotator cuff tear to see the biceps parked in there. I can see my knot. It's parked exactly where I want it. It's right on top of my transosseous tunnel. I've got my rotator cuff sutures already passed. Those sutures are passed on the medial side of the biceps. So as I tie these sutures down, they'll provide additional fixation for the tenodesis as well. So I'm just tying simple knots, and this is a little nod to Gary. You know, I'm a believer in knot tying. I think it gives us the feel that we need to apply physiologic tension or the appropriate tension to our cuff repair. I know there's a need for knotless out there with some surgeons, but I'm a believer in knot tying. And I think, you know, the appropriate tension you hold down on the post as you pass your knots is a feel thing and something that you really need to try to pass on to those that you teach. But with a Revo knot where you're passing 2 similar half hitches down on the same post, and then an alternating half hitch on the same post, and then finally alternating half hitch on a switched post. So I've switched the post by pass pointing and I need to maintain that pass point as I take that half hitch down, my knot's done. So there were some questions about stack impingement or knot impingement within the subacromial space. I really think that if you sequence 4 half hitches and you do it in the proper sequence, and you get an alternating half hitch with an alternating post as your last half hitch, you're going to have a knot that looks like that. It's not going to go anywhere. It's relatively small in profile. And I really don't have an issue with stack impingement. Maybe first 6 weeks, perhaps there's a little bit of crepitance, but after that, there's not an issue with that. So this is 3 sutures tying down the cuff. And we're seeing bone marrow coming up. We're seeing some of the biology coming up right into the repair site. And again, I always look from the lateral side to check my exit point from the bone. And I think you can see the rotator cuff looks a little mounded up there because my biceps is captured underneath of that as well. And the other point to this is that the blood supply through the cuff comes from medial to lateral. And I've got plenty of room for the blood supply to come in from medial to lateral through the cuff tissue. I don't have it closed off with a horizontal type of method or a ripstop. I'm sure Mark has numerous outcomes on his methodology and how it works. I'm just a believer that you can do this with simple suturing techniques. It certainly makes it a lot more simple for those transitioning to this technique, and it does get the job done. I had some additional slides on cost, but we've already discussed that. Again, the break-even point typically has been about 1.5 anchors to 1.5 to 2, and the cost is I believe Brett gave me a number of $520 per kit, depending on the number of cases that you do. And again, anchors are somewhere in the neighborhood of $250 to $325 just as an average, and those numbers fluctuate. I can tell you if you have a rep who's opening boxes in the back of the room and you're not terribly aware of what those boxes are, that can get really expensive. And if we're gonna start really working toward being organized for bundle payments and getting ready for direct contracting, which is something that I'm very excited about. I can very aggressively go to an employer or to a large group and discuss direct contracting for rotator cuff repairs as a carve out. And I'm in the game because of the cost containment here. And if you're part of a surgery center or part of a group that is managing a hospital perhaps, this cost containment is going to be very, very meaningful. So I can do everything from a small rotator cuff repair to a massive repair. And my cost doesn't fluctuate except for maybe the need for additional suture. Now with the Tensor kit, you get 6 sutures. I can do a tenodesis and a cuff repair with that. I can do a large to massive cuff repair with that. There's no issue. So my cost is very much contained. If I need an additional suture, so be it. It's not that expensive. But cost containment is here. The need for it is here. And we all have to be aware of that, whether we're academic or private. The downward pressures on reimbursement are very, very significant. I can tell you that the CMS reimbursement for total knee replacement at ambulatory surgery centers should be a warning to all of us where CMS would like to go with reimbursement. The private pays are going to follow CMS in that payment model. That's going to be really, really difficult on the bottom line. That's been a dramatic reduction in our reimbursement for total knee replacement. So I know AUKUS is holding off on total hips following suit. They're not going to have the total hip reimbursement follow suit with total knee. And I don't blame them for that. I think the pushback is necessary, but the dramatic reduction in total knee reimbursement should be a warning shot to all of us that we really need to be careful about our cost per case. And not only do we get to stratify and maintain our cost per case very evenly with rotator cuff repair using this technique, but we get all of the benefits of the fixation method and the biology and the reduction of pain. it's hard for me to understand, and I know Brett and I have talked about this quite a bit. It's hard for me to understand why people haven't transitioned to this. There are just so many benefits and really no downside. I know that some are intimidated by the technique and they don't really feel like, you know, they were trained on anchors and anchors are easier and all of those things. I did a weekend fellowship with Garrigues and I never looked back. I know that teaching other surgeons using the same methods that Gary used is very doable. So I will stop there.
Great, thanks, Brad. A lot of good insights there from private practice, and we appreciate your input. Next on the list, we have Dr. Cruz, who is an ultrasound expert and a burgeoning transosseous maven as well in terms of technology. So, Kevin, you want to go ahead and you should be able to share your screen, hopefully. And you're muted. Make sure you unmute.
Okay, I'm unmuted. Where do I see that option to share my screen? Oh, there we go, boom. All right, make sure I've got the right one. All right, am I up?
Yeah.
Okay, cool. All right, here we go. All right, so thank you very much, Brett, for having me on. It's pretty cool to be able to do these types of things. I think this is definitely one of like the advantages of COVID, that we realize like, hey, we don't need to fly to different places to have meetings like this, and it's still fun to go to meetings, but it's really easy to do this, you know. So awesome, thanks for putting it together, pretty cool. So Brett asked me to talk about a couple things today. I'm a huge ultrasound guy. I love ultrasound. I think it's amazing. I think it definitely cuts to a lot of the things that Brett's trying to do with his company, his technique, and Transosseous. So I implore all of you to get involved with ultrasound if you can. And then also, so looking at the ultrasound evaluations, which I've done in my career, and then also looking at pain after rotator, or pain after the repair, which I've looked at some of my SOS data, and then also looking at what I call the poor man's SCR. So, and by the way, this is my contact if anybody wants to look at that. Sorry for that typo in there. I don't know how I missed that. But yeah, if you guys ever want to email me, anybody want to give me a call about anything today, just hit me up. All right, so main points today is this going to be transosseous repair as superior biology and biomechanics compared to transosseous equivalent. And there's been some pretty elegant studies in the Japanese data that have shown this. And I actually went to Japan and talked to a lot of the guys there. I went there to actually meet Teru Mahata, but one of the serendipitous parts of that trip was meeting with a lot of like the really, really high-end orthopedic surgeons looking at ultrasound, looking at elastography, and looking at the biology and the biomechanics of cuff repair. So the Japanese are really, they're way ahead of us in terms of that curve. Looking at SCR, looking at the cost of SCR and how can you decrease that, and some of the things that I've done. And then also looking at pain from a transosseous technique, and what I found with looking at my own data, comparing tunnels versus anchors. And also I have a device that I was going to show you guys, and I didn't know if it was going to come, but it's basically like an augment for making transosseous a little bit quicker. So looking at the biology and the biomechanics, I think everybody that's spoken today has looked at this. And so this is one of the, you know, looking at the Japanese data, and this is some of the images from some of the papers that I pulled that they had. There's a guy named Itoigawa, who's a really, he's written some really good articles in arthroscopy looking at elastography for ultrasound and being able to basically use that as opposed to Goutallier for looking at the elastic qualities of the cuff, can be repaired or not. But what they found when they looked at the elastic, when they looked at the vascularity of the cuff, when they used ultrasound to actually measure the vascularity, is that they had much more vascularity at the interface of the cuff throughout the repair process with transosseous techniques versus using like a speed bridge construct, which I think we've all talked about. So, you know, with the speed bridge, it's, I always tell people it's kind of like, you know, if you fix a femur, right, you can nail a femur and it's going to heal. Okay. You could also take a femur, you could nail it, then you could open up the leg, strip off the periosteum, and put on 3 locking plates, right? So there's a limit to the biomechanics and how far you need to go from a strength standpoint to get what we need to have done. And there is the law of diminishing returns. And I think, you know, some of the constructs like the speed bridge and some of these other knotless repair techniques, it's just too tight. And we did a study when I was in Greenville with Dr. Hawkins, looking at the vascularity of the cuff with double rows and how you could easily overtension the cuff to cut off the blood supply. But they also looked at the modulus elasticity, some of the Japanese papers. They weren't able to get them to me by this talk, but they basically show that you create this interface of very stiff construct with something that's very unstiff, which is the mild tendinous junction of the cuff, and it's a recipe for failures. And so this is one of my cuffs. It was interesting. Brett, I was like, man, I ultrasound my cuffs, but I got to look back and see. I had a guy come in. He was 2.5 months out. This is a transosseous repair. And he fell, he hit his arm on the door. I was like, oh, this is beautiful. On Thursday, I'm going to show this. So this is just a quick video looking at the transosseous repair. And I would call this a Sugai of 1. I mean, that to me looks like a beautiful tendon interface. You can see the tendon very clearly. I haven't gone to the level of like med vascularity on my cuffs through the process and looking at the difference. It's very subjective to try to do that with ultrasound, but you do know when you do measure it, and the Japanese papers have shown this, that you get more vascularity from time 0 up until a healed cuff when you use bone tunnels versus ankle repairs. Just another one here. You can see the sutures through it beautifully. So this is, if you guys don't use ultrasound, it's amazing. Someone falls, they hurt their shoulder, just put the probe on there, you can show that the tendon's healed. Just be careful, because a lot of the patients that are doing okay, and you ultrasound a lot of them, you're gonna realize your failures are a little bit more than you'd like to accept. So looking at SCR, so I actually did this technique. This was like the first surgery that I did in practice. I know that's insane, but I had a buddy of mine. We came in together 5 years ago in Dallas, and he had just gotten back from Vail with Peter Millett. And so this is like right at the beginning of when it started taking off. And I had my partners just sent me all these massive cuffs when I got there because they wanted to do reverses. And I was like, I don't want to do a reverse on someone that's got full range of motion, no arthritis, and just a functional cuff tear. So I'm like, I don't know. I do a reverse on that patient. And so I flew to Vail, learned how to do the technique, and then came back, and it was my second case. And so we did an SCR on this patient, and it was like a total home run. And I remember afterward, I was eating dinner with my family, and I was pretty proud of myself, like, that I had the audacity to do a case like that, and it worked out so well that early in practice. And one of the reps accidentally texted me when they were trying to text one of the other reps that I had spent like $12,000 on the case. It was like, Cruz spent $12,000 today. I used like 8 anchors, graft, biceps, subscap, the whole thing. I mean, I was just like, and I just kind of shrugged it off because I was like, okay, whatever, who cares? And then later on, I realized I was a Medicare patient. So like, and that's our surgeon-owned hospital I did that at. So we just totally ate that whole DRG. So that's just a total lose for us. So I've been thinking, I started looking at the numbers more at our center and trying to be more of a value-based guy. And I've talking to Brett since I was a fellow about using the tunneler more. And so and when the SR started coming out, I always asked, like, why we took this very new technique, right? That's like a totally revolutionary thing, a way to treat cuffs, and everybody's all excited about it. And then we just like all of a sudden start using allografts because, Alan Hirahara and, Chris Adams at Arthroscopic says you can use an allograft. I'm like, well, you can use an allograft for anything, but we're in like a really poor biological environment, right? And we take the guy who's done literally 500 and done 5 years, right? So Tura Mahata had done 500 at 5 years. And we say, we're just gonna use allograft to see how it goes. And I was like, why aren't we doing TFL? So I flew to Japan and I watched him for a week do them. And so I came back and I was like, dude, I can do an SCR with a tunneler, 2 corkscrew anchors immediately, which Mahata, believe it or not, this is what he does on the glenoid. He does 2 old school 4-5 corkscrew anchors, double loaded sutures, passes all 8 limbs, ties 4 knots. That's how he fixes it. And then he does a speed bridge laterally because he's like an Arthroscopic guy. But you can easily do a bone tunneler laterally. And so I did a couple of these. I did like 10 when I came back. And it was kind of a beating because I'm a beach chair guy and he's a lateral guy. And he has, in Japan, it's interesting, like you don't get to become an orthopedic surgeon until you've been like a junior professor for like 6 years. So he has this guy who scrubs with him every case who's an orthopedic surgeon. And all he does is get the graft and make the graft. And they're lateral. So he's doing this while I'm trying to get the graft with one of my partners. And it was kind of a cluster. And actually had 2 of them get a P. acnes infection, right? And Mahata actually had that happen in the beginning of his practice too. He started putting ioband on the shoulder, changing some things, which I had never had an infection from a scope before. So that's why I was like, oh, I don't know if I want to keep doing this. And so what I've switched to doing now is I use the MTF allograft, which is the cheapest allograft you can get on the market. I double stack it and I weave it with tape. and I just use 25 millimeters because I don't want to pay for an extra allograft, and I double stack it. So the graft is actually 5 by 5, and so you double stack it. I look at it like an ACL, like I'm just trying to create a bridge, and then I use tunnels and just 2 anchors. So, you know, I'm spending $1,000 bucks, but it's a lot better than 12. But Mahato's an awesome guy, by the way. Like I don't think he's fudging his data at all. I think he's a really honest dude. And so these are some of the pictures of these bone tunnel SCRs with TFL. And it's interesting because when I went into the Arthrix database, SOS is amazing, by the way, if you don't use it. I know like we're kind of anti-anchors here and all that stuff, but SOS is, I've used it since I started practice. I love it. But when I type in fascia lata as the graft and you search the Arthrix database, there's one other Tensor fascia lata graft that has been done in the United States other than yours truly. It was weird to me. I was like, that's so strange. Like, why isn't anybody doing this? And it's just, it takes a long time and it's really hard. And so I think I think it's awesome because it's biologic, it's free, right? Which is amazing. But just from a time standpoint and a setup, you know, it depends on how you scope and you can do it from a beach chair, but it's just hard to get down there low enough. I think if you're a lateral scoper, it's a lot easier. But even then, you know, it's just tough. It's just tough. So this is another one that I did. And these patients all did really well, by the way. The ones that did not get infected did great. Even the guys that did infected did well. I cleaned them out and just kept the graft. So yeah, just 2 double-loaded corkscrew 4.5s in the glenoid. You can use Parkus anchors, something really cheap. And so you can take this from something that costs $10,000 when you account for the speed bridge laterally. You know, Arthrix always has 3 anchors on all their talks immediately, and they want you to use the knotless fiber tacks, right? Because that's the newest widget. Those are $600. But you can just do two anchors immediately, double loaded. And Teru Mahata does this on Japanese patients, right? So these are small people, and he's doing 4 or 5 anchors immediately, but it's unbelievably strong. And he's never had a fracture. He's been doing it from day one. And the chance to do a lot cheaper anchors for some of your more value-based products. And then just do bone tunnels laterally. And then I use an allograft now just because it was easier, but I've used a much cheaper allograft. Arthrix charges $4,000 for their allograft, which I think is insane. And so, Brad, I pulled my data. It's interesting because if you look at this, you're like, oh, well, you're starting higher. So this is like something that I pulled this week. But the one I do a hybrid technique. And so if I were to go in and really look closely at my data, back when I was using 4-5 swivel locks on the medial row, the pain score was actually, it was like 1.5 different. I think one of the reasons why this data, so the blue is transosseous and the red is anchors, right? So you say, well, the curve's a little bit steeper and you're lower, but you started higher. I think since I use all suture anchors on the medial row when I do use anchors, that it skews this data because I don't think that medial row all suture anchors hurt as much because it's such a small footprint in the bone. But a 4 or 5 corkscrew in the subchondral bone on that medial row, I think that's unbelievably. I think that causes a lot more pain in the shoulder, and I also think having tapes because of how much you overtension the cuff does. So when I looked at my data, when I was looking at true like plastic peak anchors on the medial row, it was a significant difference at the pain score. And there was the Italians actually showed that one of their studies at when they did the randomized trial, they showed 2 week and 6 week VS pain scores are definitely lower. And that's all I got for that. So I don't know if you guys have any questions. So one thing I wanted to show you guys, and I asked Brett if this is okay. I'm not trying to be like a salesman here, but so I love doing bone tunnels. I also love to be really, really efficient with my operations. And I will say for me, like taking a single row anchor and just passing 4 to 6 limbs from a triple loaded into like a lateral anchor, I can do that faster than I can do a transosseous repair because I'm just not tying knots. And so I've been thinking for a while about creating a device where you basically are just linking the sutures from your medial lateral row with a clipping device, and also would allow you to tension them all at the same time. And so it actually just came in, and I'll share with you guys a little PowerPoint here of the device. My engineer just sent me this today, so basically the whole reason behind this was, you know, talking with Brett, and we've talked about this for years. You know, why aren't guys tunneling? Why aren't they tunneling? You know, they're worried. They don't feel comfortable with the technique. They don't feel a change. So you say, okay, well, how can we get more people to tunnel? How can we solve some of the issues that, whether they're in their head or not? And so my thought was, how can you make this go faster, right? Like, how can you make this go faster? How can you make this easier? And the idea was take the knot tying out of doing bone tunnels. Simple as that. And so basically what you have is a tensioning device and a clip. And you pass your medial and lateral row. And if you can see, there's a male and female end here.
Your screen is paused.
Is it still?
Yeah.
I think you need to share your screen and pull up the other PowerPoint.
Yeah, just stop sharing and then share it again.
Okay, hold on a second. Exit out that PowerPoint. Okay, and then I'm going to share my screen again. And then we're going to go here. Okay, can you see that now?
Yes.
Okay. So just looking at the device, it's essentially a clip where there's a male and a female end. And I actually have one right here. You can see here. Where's my camera? You see there's a little clip, and there's a male and a female, and it's like a little plug. And this is 3 millimeters tall, which if you measure a knot stack, it's actually 5 to 6 millimeters. And it's like 7 millimeters across. So it's like a little clip that sits on the bone. Serves 2 purposes. One, speed, like not having to tie knots if you do a ton of suturing. And then also the ability to tension all at the same time. And I also think, you know, I know you guys have said you haven't had any cut out of bone. I occasionally do, I will cut a few out. I'm sure it's because of my technique. But I do think that in soft bone, by having that edge, a piece of plastic while you're tensioning, it will function similar to the plugs that Mark used in the past on every cup. And so the tension that you want to create with this is, I mean, you could go way more than what you need, but it's just more controlled. And just really the whole basis of this idea is speed, right? Like try to make transosseous technique faster and easier so that surgeons will adopt the technique. And so what you have is just this plug, this male and female end, the sutures come through, and then you link it to the tensioning device, you tension it, you clip it, you lock it, and then you cut it and you're done. And so I actually I've been working on this for like a year and a half. I just got the functional prototype today. So we're hopefully gonna be able to put these in a couple people this year, get it FDA approved.
Well, easy, man. Just commercialize it. Come on.
Yeah, we're close, dude. It's not, I mean, we're not that far away. Like the FDA, because the thing is that the clips, this is like a 510K, right? So like there've been many clips that have been made in the past, but there've been no clips made for like arthroscopic sutures for this level of, so we were able to patent the idea and the concept, but in terms of getting it FDA approved, it should be pretty quick. All we have to show is that our not pull out strength is good. So for me, I'm like Brett, I like to do just simples, right? Like just simple, but I'll do like 4 or 5 pieces of suture tape. And I've actually got a value company that can get you guys tape cheap if anybody wants to get really cheap tape. Because tape's actually, they're not as cheap as you think. Sometimes they'll charge you $30, $40 for a piece of tape if you're not careful. Basically, I'll pass 4 or 5, sometimes even 6 pieces of tape through a single tunnel and just do simples. And if I've got a massive cuff, I'll do 12 and just do 12 cerclages. I've just gone to just doing simples. But it just takes time for me to just go up and down the line tying like 10 or 12 knots on a big cuff. So I figured you take them all at once, you can clip it, and then I've actually got another design for a suture that's specifically designed for tunneling, where you basically have 1 limb of suture that spreads out into 6. So then you're just funneling 1 limb of suture in through the tunnel, and then you pass your 6, so it's like a triple loaded anchor, then you would go 6 to 1, clip and lock. Just simple. And it's just a way to basically add to Brett's device to make it a little bit faster, a little bit easier.
Cool. Thanks for that, Kevin. And I'd like to just point out a couple things that he talked about. I mean, there's an order of magnitude cost reduction possible with SCR. You rarely see that in the device world where you can have literally an order of magnitude reduction. Maybe there's still a few pain points there surgically, but that's very interesting to me. The pain reduction as well that you noted about, I've heard that as well from anchor companies, that even the soft anchors medially, anything, the hard anchor on the medial side causes the most pain. And even with my hybrid techniques, 1 anchor laterally, I don't see a big introduction of pain, but we definitely see reduction of pain with less hard anchors as the medial row. So I've got one more thing, if we can hang on here. Hopefully we've enjoyed it. I'd like to close it out with a couple of points. And here we go. Again, my disclosure. So I've done a lot of work on hybrids, and this stress point medially was one of my big concerns. the soft bone questions that we've heard, the knot tying questions that we've heard. I've heard that from all the surgeons, so I was trying to solve that. If you look down here at low, Sano and Itoy have shown that the stress riser medially is eliminated by transosseous. So that's going to be your salvage of the type 2 failure. So that's been shown in those studies. You know, Dr. Rodeo and Shukumaran have all shown us that everyone was talking about single and double row, and there was no difference, and no one was controlling for suture number, which is the really important thing. And now that we can do repairs with a lot of suture in them arthroscopically fast, you know, very fast in the OR, we're back to this concept that I really want to emphasize, which is we want high fixation point density per surface area for load sharing, and number of sutures per fixation point. That is what is important in terms of strength. And this is probably the most ignored study, you know, in the literature by Gus Mazzacca and Bernie Bach, and these guys are not slouches when it comes to research. On the right, you'll see this is Dr. Cole's slide at the ESH meeting showing 350 to 400 newtons with transosseous equivalent. Look on the left, the multi-suture technique, which is done like this in the lab, was 856 newtons ultimate failures, higher than an intact cuff. They were actually ripping the surgical neck off the specimens. So this, you know, we can do this transosseously now if you want to. You don't have to, but again, that's that ceiling that Dr. Shukumaran was talking about. This was the first hybrid I did in practice. We looked this up in AJSM 2007. Hybrids are there. This one had 400 to 500 newtons, very strong failure. So again, we're just trying to optimize the variables of time, cost, fixation, and usability. And what's the best mixture of that? You know, how fast do you want to go? Is that what you want to go for? Or do you want to go for biology, or do you want to go for cost? All of us have different personalities there. But that's why, that's what led to multiple different techniques that eventually we landed on this true transosseous hybrid. So this is essentially an X-box repair where you leave the tails long and then bring one anchor down immediately. And so this was meant originally to address the concerns that we've heard about, you know, is there soft bone? So it gives you a fixator if you want it, but not multiple fixators. And it gives you a chance to retension, you know, and have a knotless last step. There's no anchor burden at the footprint, only microfracture, which, as we know, is the only thing that's really been shown to improve healing. It's a triple row, which, if you care about that, it has cortical augmentation, and it's improved cost per you know, multiple fixation points. And it's a self-reinforcing construct, just like a transosseous equivalent repair with anchors. So this is what it looks like from posteriorly. It looks just like a transosseous equivalent with anchors, except there's no anchors. And it just has one anchor laterally. There's no anchors in the healing zone. And here's one from laterally with tapes and an anchor. And again, echo other panelists, tapes, anchors, when you use all these together, you're really probably superseding what you're seeing with some of these other techniques that are anchors only. These are my results of my first pilot study, 143 patients over 14 months, 5% re-tear with transosseous, 4% with the hybrid, over 40-point increase in ASES scores. And I saw more pain and decreased ASES scores in the anchors. You've seen that in some of the literature as well. I would like to show how the tunneler is deployed and how fast it can be. So here's the technique. We clean out the lateral gutter. Here's the device, one-handed operation. We go in inverted, we pop through the subdeltoid fascia, and then we rotate up to the hole, 2-9 hole, which has been made medially with an awl, just like you would for an anchor. We pop in there and rotate as far down as we can. We can get about an 18 millimeter, maybe a 2 centimeter bridge there if you can rotate down. Just one mallet in and back out with an assistant. It stays in place by itself. You can let it go if you want. And then we're done. So it's just a little over 20 seconds, and that's the equivalent of 2 anchors that just went in there. So it's 2 fixation points. And then we pull out the managing suture immediately and pass our triplet. So 3 sutures for me is the optimal number for efficiency and strength balance. We pull the triplet through. So the triplet, for me, is the functional moiety of cuff repair. And then we manage these sutures topographically. So the anterior sutures on the skin are anterior inside the suture, inside the shoulder. We use colored roach clips, my team calls them. And they're clipped statically down below and dynamically up to the drape. And so we do that on both tunnels. That's what they look like, very similar to anchors. And then this is a key step. We take the cannula and exclude the sutures inferiorly. So this makes the repair exactly like an anchor repair. So you can manage the sutures exactly like an anchor repair. So you pass those sutures, and then here we're gonna bridge the tunnels. So we're gonna make our mattress suture, and Dr. Lazarus, I believe, was doing this the same way, shuttling them. In this case, we're gonna leave the knot on top, but we're gonna bring it down at the end of the case. So some people had concerns about tying knots, so we tie this extracorporeally outside the body and then pull it back in. You can see this on arthroscopy techniques. I won't go through the whole thing, but we'll tie this simple, and I'll show you. You can pull the knot stack where you want it to maximize shear and compression. So you can't do that with anchors. You can put the knot where you need it to maximize whatever you're trying to achieve. And here it is when we're done from posteriorly. So we bring these anchors down, one anchor down, and interlock below the lowest limb there. So it's self-reinforcing and it interlocks itself. So that's a five fixation point repair with one anchor. So that's a force multiplier. And I think we can have kits where we can have an anchor and use it, and I'm not against that. Sometimes you want the best of both worlds, but we need to do this with biologics as well. So my pearls would be low portal placement, topographic suture management, and suture stabilization with the cannula. This single row repair is excellent. I think that may be better than anchors. Here's a single tendon. I use an X-box and a racking hitch here. And then for the big ones, we use 3 or 4 tunnels, usually 3, and similar to Dr. Lazarus there. Or that's all transosseous or a hybrid. So you can do that, leave the tails long, and then bring one anchor down if you desire it for some reason clinically. And again, this single anchor cuff up here, that's Mason Allen sutures with 2 simples. I can't make a single anchor look like that. So that may actually, be good there. We had questions about bone mineral density. It's a Gaussian distribution, and above on the top, all fixations work, so it's dealer's choice. There's nothing to worry about. Down below, everything fails, and the ramification of a suture cutting through is much less than an anchor pulling out. And here is where I think about hybrids or potentially augmentation, where you might want to throw an augment in there. And you can see from the nomogram on the right that most of the osteopenia starts around 75 in the females. So there's a ton of cuff repairs between 40 and 75 that can be performed. One thing that accounts for, I was on a panel recently in July with the Transosseous Academy, and we were talking about, and all the panelists said, I have 1 or 2 cutouts a year. And I think that's indications. The 85-year-old female with butterbone who has an irreparable tear gets a reverse now. So I think that's changed the game in terms of the number of suture cut-throughs. We have a lot of different options to treat cuffs. And there's also some device-related things about the way we do it, where we don't drill and we compact the bone tunnels, so we make them stronger instead of removing bone to deal with that. I'll show you some soft bone case pearls here. This is one of the softest ones we ever did, and the awl was able to be pushed in, and I was able to actually push the ablator head just directly into the bone. It was that soft. He actually ripped in the top picture, he ripped the cortex off of the tuberosity there. So this is a huge, 18, 2 centimeter, 20 millimeter defect that you'd have to stack anchors or graft. And so what we did was tunnel through that with 2 tunnels, and then use an ACL button, and then anchors around that. I call that an anchor bounded technique. So you can spread out and load share, increase your fixation point density, and think about a technique like this, And this is what it looks like on the x-ray. This guy had an ETOH problem and fell after surgery. And you can see he tried to fracture the tuberosity, but it held. Here's another augmentation strategy. These are commercially available peak cortical suspensory devices. And again, I would challenge you to say that that's not approximating a very strong anchor repair with very good biology medial, no anchors medially. Here's another new technology. We had a question about resorbability, and so this is a massive reverse L-shaped tear that we fixed with transosseous technique and absorbable buttons on the cuff and on the bone. So we're solving both sides of the problem there with new technology. And this is probably the major advantage of the cost ceiling effect of reducing the cost, is that we can actually legitimately bring in new technologies and utilize them together, even separate from the bundle issue. But you can also use tapes, screws. We've used cement, bioabsorbable cement, and some magnesium or calcium phosphate cement. So there's a lot of different ways to go here. Here's the video of that one, multi-fixation point. That was 6 fixation points, I believe. Excellent articular reconstruction here. And again, the biceps, we don't want to forget about that. So here's a real-time biceps tunnel with the arm forward flexed. I like to interlock the sutures perpendicular to each other. We don't drill, so I feel really confident, bringing the awl through these, splitting the uprights here. We just observe that. You can do this around anchors too, and you can skive past them very easily. Here you're passing the suture, and then it's passively retrieved intraosseously, and then you don't have to worry about any actuation of any nitinol wires or anything. You just pull it out. So there we are, we're done. And you can get a very nice fixation here in the hardest bone of the humerus. So this is my technique for this. You can see in the top corners, there's a lot of different ways we've used to capture the biceps, sort of like an ACL graft intra-articularly. And the older version of this just came out in Arthroscopy Techniques if you're interested. But here's a hybrid. And that is 3 tunnel. So 6 fixation points plus an anchor, that's 7. And then 8, 9, 10, 11 there in the front. So 11 fixation points. Just a bit about outcomes. We didn't mention many outcomes, but there are, the studies that are available have great outcomes and very high ASES scores and decreased cost and level 1 evidence of decreased pain. We've got this 12 to 18 year follow-up out of Herbert Resch's patients with a mean ASES of 92 at 12 to 18 years. It's amazing results, very high repair integrity for this long. So I think we can extrapolate that. So to go back to the common themes, we've got equivalent outcomes and biomechanics, less type 2 failures, less pain, decreased cost, improved biology and revision considerations, better MRI healing characteristics with transosseous, and ability, and the sky's the limit in terms of future technologies with synergies with the multi-fixation point within a case that you can achieve with transosseous. So I would implore you to try to maximize outcome and minimize costs. So with that, unless there's any other questions, I appreciate your attention. We're pretty close to being on time here. If anybody has any questions, you can contact me below. We thank you for your attention tonight. And don't hesitate to send us any questions online or by email. Any other panelists have anything to add?
When you guys do your posterior, like Mark, when you go to 4 tunnels, are you putting your tunneler in through your posterolateral portal? And Brett, what about you as well? I mean, are you going in through a different, or can you pop all from your anterolateral?
I go all from the anterolateral tunnel, just progressively internally rotating the arm. And,
okay.
And I've done 5. So I've done 5, which was a chore and a half.
Now, the one thing I get is, like, I worry sometimes, I guess maybe like when I'm doing it, I need to make sure when I start in the front, I need to really I need to be externally rotated and really get the tunneler far forward, because if you're not careful, you'll get crowded laterally.
Yeah,
Are you a lateral scope or a beach chair guy?
I'm a beach chair guy, and that's one of the advantages, is that you can just progress. It's very easy to just progressively rotate the arm as you go. But that's the advantage of tunneling. Just for the anchor people, there's no minimum distance medially, right? That's the beauty. Anchors, you have a minimum distance, on the medial side off the articular margin. There's no minimal distance. You could put them all in a single hole. Doesn't matter. But what you do need is you need a minimum distance laterally for your horizontal mattresses.
Gotcha. And then when you do that, you're rotating. I know you said, for me, like, I have to bring the arm down to make sure that I can get my arm medial enough, like on the footprint. But how far out do you bring it when you? I always try to drop my hand down, as far as I can laterally to get that. But how far are you abducting the arm to get even more lateral? And Brad, I don't know if you do that, or Uma or Brad.
I definitely abduct. I don't try to go. I don't do it dramatically, but I'm definitely conscientious more of where my lateral tunnel is going to be as I start maybe a 3 tunnel repair. I don't want to cheat myself posteriorly. Sometimes if you start too far posterior with your first tunnel, which is the anterior tunnel, as you work toward the back, your last tunnel may fall off of the back of the crescent shape of the rotator cuff tear. So on occasion, you'll get a loop of suture that goes over the back edge of the crescent. Not the worst thing, but you want to be careful about the convergence on the lateral side. So I definitely agree with starting a bit more anterior with the first tunnel, so that leaves you plenty of room, and be very conscientious, especially in soft bone, about the distance between the exit points on the lateral side. Spend some time debriding out that gutter, remove the synovial tissue there, make sure you have a clear view. Make sure you use a high posterior lateral viewing portal so that you can look around the corner. I think a room with a view with that additional portal in the back is really critical to being able to see down through the gutter, and making sure that you can start anteriorly with excellent visualization. Dr. Snyder was commenting about working on an Alex model, and I don't think Dr. Snyder needs to work on an Alex model, quite frankly, but I think the key issue with that, if I was talking to Dr. Snyder about the technique, it would be, just be very conscientious about convergence on the lateral side. Mark that 5 tunnel repair. I'd love to see the pictures of that. 4 is the most that I've ever done. 5 is just like, wow.
Was it a subscap?
No, that did not include subscap.
Wow.
That was a supraspinatus, infraspinatus avulsion. We had to figure out, have a plan. What I said before, you had to figure out like what suture to use. We went to number 5 Ethibond because I'd run out of every other type of suture that I could think of, and I wanted something of a different color.
Yeah, you got to have a rainbow. That's the biggest. That's what I wish they had more colorful sutures.
Yeah. If you sequence properly, I've been stuck in cases where all we have is white today, Dr. Brodigan. It's like, okay, and so I've been in cases where it's all the same color, and as long as you sequence, and I really like Brett's technique. If you sequence properly and use the crochet needle to reach around and grab the proper suture in the proper sequence, and do a little pull test on the sutures, it's doable. The different colors definitely help, but if you follow the steps, it's very doable, even if it was the same color suture.
What about big subscaps?
Not a problem.
I just love them. They're the easy. They offer the advantage of you don't have to pass double, mattress sutures under the strap muscles. You pass simples. The bone is always hard, and it comes straight back. You can incorporate the biceps simultaneously. So a lot of times I'll do a locking loop on the biceps, and you can with the Transos, you can penetrate through the biceps on purpose and just snag it. And it's a 2-for-1. I love those. You can do it intra-articularly as well. What's that?
Will you do 2 tunnels in the lesser, or will you just do 1 tunnel past 4 and do cerclage?
2 tunnels usually, and then sometimes 1 in the interval if there's a big cuff tear, so, you can get up to 6 to 9 tunnels and some big 3 tendon tears.
But you'll do 2 tunnels in the lesser though?
You can, yeah.
Yeah,
okay.
Absolutely.
Yeah.
Okay.
So a little abduction, external rotation. Again, that posterior lateral viewing portal is critical. So you have the room with view so that you can look around from the back. You don't have to move your scope around. You still have, you might have to look around for preparation of the lesser, but the tensor is going to come in from the interlateral portal. You're still looking from the back. So right off of that high posterior lateral corner, right off the acromion. So for those of you who only use one portal in the back, if you use like the typical mid-glenohumeral portal in the back, and then you use that same skin incision for your subacromial space, you're cheating yourself. The additional 4 to 5 millimeters from your mid-glenoid posterior viewing portal to the high lateral portal right underneath of the acromion, it makes an enormous difference, and often is the thing that transitions you to being able to do this procedure. So if you're stuck high on the ceiling and you're looking down, you have a room with a view, and you can look around the corner and do the subscap. You can look down through the gutter. You have such an improvement with visualization. It's hard to imagine you get that with a 4 to 5 millimeter difference on the skin side of where the incision is located, but it is dramatic to have that additional posterior portal. And as far as the subscapularis goes, it's really using that posterior viewing portal, abduction, external rotation, and just looking around the corner. And it's very similar to just working through the greater tuberosity at that point.
Okay. All right, next big one, I'm going to tunnel it.
That's also how Brett does his biceps tenodesis, working through the groove. He's in the same spot, same angle.
Yeah, so I was thinking about your technique, and I was like, because I do a loop and tack, and I can literally do a loop and tack, like where you basically just go around once and then pop it through, and then do like a push lock at the top of the groove. And I've done it in 45 seconds, like literally 45 seconds. But I feel like I could do the same thing with the loop and tack, but just take one limb and pass it through my tunnel, my anterolateral supratunnel, like you do, and just tie it over the top of my cuff, and it's easy. And that's how I do a lot of my, sometimes too, like you guys want like a biceps tenodesis hack, is if you just go to the subacromial space quickly. What I've done, especially in older patients where like you just want to do no anchors whatsoever, like we're just trying to, especially Medicare patients, you're trying to minimize costs because your DRG is so low, is with your anterolateral tunnel, if you make it really, really far interiorly, like way almost at the edge of the bicipital groove, just pass 2 or 3 of your sutures through the biceps when it's still attached to the glenoid, and then pass them through the cuff, and then just tie them down. And you'll have 3 to 4 sutures through the biceps tendon, and it's going to stay. I mean, you have 2 to 3 sutures, and then you just cut the biceps, tie your cuff, and boom. And then you literally, that's a 1 second biceps tenodesis. And it's through a tunnel, it stays, they don't come loose. I've done it many, many times. And it is, and by the way, you're tensioning it perfect, right? Because you're passing the sutures through the biceps while it's still attached to the glenoid. You understand what I'm saying?
Yeah, I leave it attached for my technique because it's perfect tension. And then I had a few failures early with very small tendons, and I go back in afterwards and release it with a small piece of labrum that hangs up in the groove. And I've had 0 failures with that. And relating to your SCR, you can use the biceps autograft, leave it attached to the glenoid, and bring it back through a tunnel. You can whip stitch it and use that as like a biologic cheap SCR that's available.
South Koreans have actually published on that and doing like a lot of really crazy stuff where they go way down deep with the biceps, and they've actually had like a quiff fancy ways of snaking the biceps around to make it an SCR. And I know that Jeff Abrams has talked about doing that too. And Rob Bell put that in his book somewhere, Brad. I don't know. Rob Bell used to come to Greenville every single year because he's like Dr. Hawkins' boy. He's just a really, really nice guy, man.
He's the talk first fellow, and they're super tight. So, one thing about the biceps tenodesis and why I transitioned to fixing it through the tunnels on the greater tuberosity, Butch Krishnan, who did my biceps, did it that way. And my tenodesis held up well despite non-compliance. I don't have groove pain. I'm concerned a little bit about groove pain. So I started to transition my tenodesis technique to the greater tuberosity and not fixing anything into the groove if I can get away with it. Now, if I need the additional fixation, I'll go to the groove. But if I can fix it to the greater tuberosity with a little bit of additional preparation of the greater tuberosity to give the biceps some room to sit down and allow the cuff to come in over top of it. I don't want the biceps to prevent my cuff from healing, certainly. It's like a soft tissue interposition between the cuff and the bone. So you do have to prepare the greater tuberosity a little bit more. But avoiding the groove does have some advantages for the patient, and I can speak from my own experience. So, and it's a little bit of a learning curve to incorporate the biceps into the same space as your cuff repair. But after you get the steps down, it's really not that much more difficult. And Brett's technique is super solid. So for the guys that are heavy laborers and potentially non-compliant, I think Brett's technique is probably the best technique that I've seen. You know, using that mattress technique and then using the hard bone of the groove. You know, his tenodesis fixation isn't going anywhere. So I think having options is fantastic, and this device gives you those options.
Yeah, for sure.
Awesome. Well, great webinar, guys. Thanks so much for participation. All the attendees, thanks a lot for sharing your time with us. Anybody who wants a copy, email me. We'll send you one, and let's look forward to another one in the future.
Thanks, Brett. This was great. Great job organizing it.
Yes, I totally agree. Thank you for inviting me.
Good stuff, man.
Take care, guys.
Very welcome. Y'all take
You
care.
guys.
Later.